Hi, I'm Dr. Orlando Landrum from Cutting Edge Integrative Pain Relief, and we're going to teach you how to be able to biohack your pain. Are you having pain that's in your back or pain that's in your back and radiating down your leg, and your doctor's talking to you about doing an epidural steroid injection? Have you had an epidural steroid injection? If so, and you're thinking about it, or you've had it, there are 10 things you need to know, and you need to know them now. If you're interested, stay tuned. Dr. Orlando Landrum, a Harvard and Cornell trained MD who specializes in interventional pain, regenerative medicine, and neuromodulation techniques. I've helped thousands of patients be able to get their lives back and eliminate their pain. Epidural steroid injections for low back pain, 10 things that you need to know now. We're going to walk you from 1 through 10, give you insight about each one so you have an understanding about what's going on with your body, what are your potential benefits, and what are your potential risks, so that you can make an informed decision and one that gives you the best outcome for you to be pain-free and be able to be functional and do the things that you want to be able to do. Epidural steroid injections are different than a labor epidural. The two are not the same. They are done differently. They have a different mixture that's put into the body. And traditionally, the type of doctor, although they may be similar, the doctors that are doing epidural steroid injections typically have a little bit of extra expertise in terms of the placement and understanding of the tools that they'll use to be able to get into the space. So the picture that we have on screen right now actually shows two different pictures. One that's present on the right-hand side, one is present on the left. The one on the right-hand side denotes a labor epidural, traditionally done for someone that is going through labor, is close to delivering, and needs pain relief. For that person, they're normally going to experience a 2E needle that's going to be placed in the center of the back, low in the lumbar spine. The reason why it's done low in the lumbar spine is so that way it's below the ending of the spinal cord, and there's little risk for that needle to touch that area. The picture on the left is a picture of a traditional pain epidural steroid injection, which is an injection that's done from multiple different angles, but traditionally is done from quote unquote the side or a transforaminal approach. We're going to go into more depth and detail about this, but it actually is pretty important in terms of outcome as well as potential risk. So when we look at the context of an epidural steroid injection, there are a few things that we need to see. The first is the type of needle and the approach. So for a labor epidural, which if we're using a spine model that looks like this, normally what's done is the needle is going to be placed in an orientation like this. And so what that shows is a needle that's going to be between the two lamina in the center of the back, versus a transforaminal approach where that needle is going to come from the side. And that needle from the side, when you take a look, is going to be a needle that shows into and around the exiting nerve root. The reason for that is because you want that needle to be able, and that injectate or the components of the liquid that's going to be placed in the epidural space, to be close to the nerve root and be close to the disc. So differing approaches for differing results. So going into more in depth and detail, the different approaches include an interlaminar approach, a caudal approach, and transforaminal. We discussed the interlaminar approach, which is right in the center. It's traditional for a labor epidural. However, it could be done that way also for epidural steroid injection. A caudal approach, which is a needle that's placed at the very bottom of the spinal canal, where the needle enters near the coccyx or the tailbone. There are a number of reasons for why that's done. We'll cover that a little bit later. And the other way is a transforaminal, which is shown in the picture on the right-hand side, and we just denoted a way to be able to do that earlier, where that needle approaches from the side. So as a patient or someone who's considering having this done, why is this important? Because the different experiences that one may have had when you had a labor epidural may be completely different from what will happen when you have a transforaminal epidural steroid injection. The reason why is it's a different type of needle. It's typically smaller in size. It normally doesn't have the same type of sensation that you'll feel when the ligament is trying to be contacted, because to do a labor epidural, the needle has to go through a couple different areas. Specifically, it has to get into something that's called the ligamentum flavum, and that sensation is what causes a loss of resistance or potential vacuum that takes place that allows the person placing the epidural to know they're in the right space. For a transforaminal approach, it's completely different. The needle is clarified by using contrast dye that we're in the right space, or typically the use of radiographic imaging in combination to show where the needle tip is so that we can be certain that we have the right placement. So when was the first epidural done? The first epidural was done in actually 1901, many years or so ago, and it was done from a caudal approach, the approach that we mentioned before, which is at the bottom of the tailbone. It was actually denoted by two different individuals who weren't working collectively together. And they, at the time, used cocaine because it has a local anesthetic. It makes things numb. After a number of years, there was further insight put into place that maybe cocaine shouldn't be utilized as a routine element, and we might be able to do some other things. And so there was actually the placement of the traditional approach, which is that interlaminar approach that we talked about earlier, kind of right in the element of the center of the spine, that was developed by a Spanish military surgeon named Fidel Page. That was used mainly for battlefield as well as post-operative pain control. And then we started talking about epidural steroid injections. We really weren't able to do that until we had cortisone. And that's the picture off to the right-hand side, which was not developed until 1936. It was used in a whole host of different contexts, but the first time it was used for an epidural steroid injection was actually in 1952. In this regard, what steroids are used? Is it always cortisone? No, there's a whole host of different steroids that can be used and traditionally are used. Right now, probably the most common steroids that are used in an epidural steroid injection are going to typically be something that's called Decadron, something that's called Kenalog, and then depending on the doc and their choice, either Celestone or Depomedrol. Those are the kind of the mainstays for what are typically used. Nowadays, the reason why docs would particularly use one versus another, number one has to do with the length of action and how long it would last once the injection is there. But most importantly is something that's called particulate aspect. So the particulate nature is whether it has a sediment that's present there. Historically, we have thought about using a particulate steroid because it was thought to last longer. But nowadays, most docs will choose a non-particulate steroid because it is safer. When and or if that needle gets close to aspects of the vascular supply, the arteries and veins, what we don't want to have is particles that are going into those areas that can cause problems and issues. So traditionally, a doctor is doing a non-particulate steroid injection. So one of the things that you want to ask if you're going to have an epidural steroid injection is, are they, referring to the doc or the person who's placing the needle, are they placing the needle and injecting you with a particulate or a non-particulate steroid? It's actually quite important and is one of the ways to be able to decipher should you even consider having this go on and take place. So when is the best time to get an epidural steroid? There haven't been a lot of studies that have really aggressively looked at this, but there have been a few that have assessed the aspect of the optimal time. Most of the time, when someone has back pain and leg pain, they don't need an epidural steroid injection immediately. It can typically work its way out, or it is self-limited, is another way to be able to kind of say that. Secondly, sometimes doing physical therapy or exercise can be able to improve this so that an epidural steroid injection is not needed immediately. However, the better outcome is somewhere between not too soon, but not too late. And so when you look at the best outcomes that have been meta-analyses where they pool research data and look at multiple different treatments and what those treatments from research papers have shown, traditionally, the earlier you get the steroid, the better the result's going to be and the much more longer lasting it can be. So one of the things that has come up is, so if you do one steroid injection, if it doesn't resolve it, is there a time that makes sense to do a secondary injection? And historically, there have been a number of different methodologies and thought processes about whether it should be stacked or whether it should be spaced. So stacked meaning that you have a steroid and then another one's done and another one's done in close proximity. The concern for that is now you're getting an increased steroid load, and so do you have side effects accordingly? But the fact of the matter is there was a paper that actually looked at an acute stacked model, meaning the epidural steroid injection was done sooner and the actual injections were done close together. And what they ended up seeing was that it was a better result with a cumulative course of steroids put together closely as opposed to spaced far further out. The challenge with that is that if the patient has a recurrence, you don't want to increase and do multiple different steroid injections that then can result in some side effects. So what are the indications for an epidural steroid injection? So one of the indications is if you or the person that you care about has radicular symptoms. The other way of saying radicular symptoms is a sciatica, a radiculopathy, meaning that pain doesn't just stay within the context of the axial spine, but it moves down either the arms or it moves down the legs. And in that context, traditionally the nerve is irritated for a number of different factors, and those factors can be ameliorated with the use of the steroid and this anti-inflammatory type process. So there are some other reasons for why a doc or other provider may consider using the elements of steroids, and some of those include spinal stenosis, degenerative disc disease, lumbar disc herniation, spondylolisthesis. Many of those things will not have their origin or underlying state changed by steroid usage. However, they can impact some of the sequelae, meaning some of the issues for why you have radicular symptomatology. It may not change, but it can impact those symptoms that are bothering you, that are shooting or burning or tingling, that are occurring down the arm or down the leg. Do steroids always work? So if you're a good test taker, you know that's not the case because always, there's no such thing as always. So steroids are going to be more successful in those individuals who have good anatomy and don't have tissues that are stagnant and won't respond. So the times when those tissues may be stagnant and why you might have problems and issues are going to be if you're a smoker, if you have previous spine surgery, if you have other potential issues that cause you to have increased pain sensitivity, if you have the aspect of some existing opioid use before, your likelihood of getting a drastic improvement in terms of pain from the aspect of steroid is going to be reduced. One of the things that we also want to have some idea about is, does the approach, meaning if the needle is that interlaminar approach, transforaminal or caudal, does it give you a better result? The graph on the right-hand side shows that transforaminal is a little bit better than the two other approaches, which is one of the reasons why it's most commonly done. However, there are times where those other approaches make sense and are appropriate to do. How frequently can you do epidural steroid injections? One of the things that you also want to know. So if you've had 2 injections, should you have a third or a fourth? My patients frequently ask me this question. And the fact of the matter is, like many things, it depends. So why does it depend? It depends because number one, we need to know the type of steroid and the concentration that was used. And more importantly, we also need to know what are some of your underlying medical conditions. So if you're diabetic, we know that steroids are going to change your blood glucose or your blood sugar, if you would. When those things change, if you happen to have a hemoglobin A1C or a traditional fasting blood glucose that's high and elevated at baseline, we know we're going to bump it up and cause a whole host of other different problems. And some of those problems can be everything from you having changes in your eyesight and the underlying problems of the eye, to changes with your kidneys and your renal function, to changes with your endocrine system and how your brain and adrenal and other parts of that endocrine system or hormonal system actually talk to one another and produce what's needed versus what's not. So all those things are hugely impactful to how frequently you can be able to do an epidural steroid injection. The classic assessment is that traditionally you want to have maybe 3 or 4 steroid injections maximum for a year, but there are certain individuals who probably can't tolerate that at all, and there are certain individuals who may be able to tolerate a little bit more. So it's an individual guided therapy in terms of that type of assessment. So, what are some of the possible complications of steroids? This is really the nitty gritty of us making some understanding about should you even consider a steroid injection or should you not? So, there's been a number of different articles that have talked about this, from everything from the New England Journal of Medicine to Newsweek and many multiple different research papers that have assessed this. So, let's talk about some of the basic, most common side effects of a steroid injection. So, number one, the first thing is if you're diabetic, it can cause you to have an increased blood glucose. And there are different things that can happen with that. You can have different changes in terms of your fluid status, and you having increased extracellular fluid. So, if you have the aspect of congestive heart failure, it can be able to cause you to have some challenges of being able to lay flat, and other elements along those lines where you might have to use a diuretic, meaning something that helps you be able to get that fluid off by having an increase in your urination. Secondly, if you have a low bone density and you know that you've had either falls or fractures before, from that fall, having an increased steroid use can potentially put you at risk for a likelihood of further fractures. So we need to be cognizant of that. If you have other issues like kidney or eye issues, as we mentioned earlier, we need to be a little bit more thoughtful in how we treat in terms of epidural steroid injections and how you as a patient make concomitant decisions with your provider about should you have this or not. But some of the other things that are a little bit rarer are things that actually can occur, and many patients are always surprised about this. So this is one of those kind of like nitty gritty pieces that your doctor may not necessarily tell you about, but you'll know because you watched this video. So can you have mood swings? Yes, because it has central nervous system changes. Can you have nervousness? Can you have appetite stimulation, meaning you just want to eat everything? Yes, you can have that because of the steroids. Can you have increased itching? Can you have facial flushing? Yes, you can. So let's talk about some of the ominous and rare things that have happened. So if you take a look at that Newsweek little icon on the left-hand side, there was the aspect of a few years or so ago, an outbreak secondary to a fungal infection that took place at compounding pharmacies. And those patients that got injected with steroids from those compounding pharmacies had a whole host of different issues and problems that are actually some of which still lasting even to today. 800 people across 20 different states were infected, and 60 of those actually died. And so when we take a look at where that doc or healthcare provider is getting the steroids from, most are not using compounding pharmacies any longer because of this outbreak that took place. However, it's a question that you really need to pose so that you have an understanding about what's your safety and how you can be able to have a good outcome if you decide to choose an epidural steroid injection as a potential benefit. So, what is another alternative to epidural steroid injections? You say, you know what? You told me that I might get 70% relief and improvement in pain. I might get 50% pain relief. I know the different approaches that are going on. However, there's a whole host of different reasons for why I might not want to choose steroid. It can increase my blood glucose. It can cause problems with my eyes, with my kidneys. It can increase my potential risk for a fracture. So, do you got something that's better? I mean, it's actually progressing. It's 2020. You know, what can we be able to do instead? So there is another actual treatment option that mimics some of the good effects of steroids, but also decreases the challenges that are in place. And so one of the things is something that's called platelet lysate. In essence, it's an autologous draw, meaning you're taking blood from yourself, and you take those platelets and you use both a centrifuge technique as well as some other changes in order to be able to have the platelets open. And that opening of the platelets results in a lysis. And those factors injected in and around the nerve in the same areas as what you would utilize for an epidural steroid injection can give you not only an equal amount of pain relief, but typically even a better amount. But most importantly, in addition to that, it also can give you a much more sustained pain relief component, meaning more than months, sometimes years, if not longer. So one of the things to look into is the context of platelet lysate as a potential benefit for having those radicular symptoms that you would normally use an epidural steroid injection for. Are there other things that might be able to improve an epidural steroid injection outcome in 2020 and beyond? So these are the things that you want to talk to your provider about to figure out, are they doing the things to make sure not only do you have a good outcome, but most importantly that you're safe. So if you take a look on the left-hand side, these are all the different things that can happen, and how to be able to prevent this is huge. So can you have a vasovagal reaction? Which a vasovagal reaction is their stimulation of the vagus nerve, which causes you to have this drop in blood pressure and really kind of have sometimes a fainting episode that can occur. Can you have a dural puncture where the needle goes a little bit too far and gets into the CSF fluid and causes a CSF leak, with traditionally a headache that happens afterwards? Can you have something that's called pneumocephalus, where there's an injection and air goes into the aspect of the CSF and causes some other challenges that could typically result in a headache? Can you have paresthesias, which are kind of tingling and sensation that goes down the nerve and sometimes can result in things like a nepraxia, where you have a problem that lasts for a long-term time with that aspect? Can you have hiccups? We all know what hiccups are, but the cause is because of stimulation of the vagus nerve or the phrenic nerve that then results in you having to sustain hiccups for a period of time. And can you have flushing? So all those things can certainly occur. Some of them are much more rare than others. And one of the things the doc needs to know how to do is how to be able to treat it or how to be able to prevent it. So if you know that you're susceptible to having a vasovagal reaction or a potential fainting episode or changes in your blood pressure, then what they may want to consider doing is having at least the ability to be able to give you hydration or IV fluid by having a hep block in place, or already have you loaded with some degree of fluid, assuming it's not going to cause you a problem or issue. A dural puncture, there are ways to be able to kind of avoid that based off of the type of technique, how they progress with the advancement of that needle, and what are some of the ways that they can be able to prevent that from happening, assuming you're within a higher risk group. The aspect of a post-dural puncture headache, where that headache takes place, there are things you can do to treat it. There are things that can be done to be able to avoid it if at all possible. That paresthesia and nepraxia, where you have that tingling that goes down the leg or weakness that results, there are ways to be able to try to be able to prevent that from occurring. And if it does occur, how to be able to deal with that. The flushing. There are ways to be able to provide something like antihistamine, like a Benadryl, to be able to treat that from occurring. So these are all the different ways that you can be able to treat various different issues that can arise or potentially arise with the aspect of an epidural steroid injection. So you have now understanding of epidural steroid injections and what are some of both the benefits as well as what are some of the drawbacks, and how you can be able to have a better understanding about what you're getting yourself into. If you are looking to have further information about making good informed choices for how to be able to decrease your pain and improve your function, please tune in to the rest of our videos on our channel and continue to look for a video that's released every Friday so you can have a better understanding about how to be able to live your life better and how to be more happy in terms of decreasing your pain. Thank you.